talk is on incidental and pathologic findings on brain MRIs during routine surveillance. And this was inspired by, I guess, repeated experiences with MRIs being read both at outside centers where they were reading things that were benign as ALD lesions, and that of course was very scary for families and led to confusion for the families and the doctors both. And it's not fun for the radiologists to do that either. They definitely want to get it right. The neurologists want to get it right. And so we sort of realized that this was a recurring problem and needed some clarification. We also were seeing things at our own center where we had people looking at ALD MRIs all the time, and we were seeing things that we were initially not sure how to interpret. And so I'll touch on both of those things. My disclosures are not really very relevant here, but I do some consulting, have several grants related to ALD, and do some nonprofit work. This is current state of newborn screening. This is a slide courtesy of Miranda and Elisa. And a really nice update here. This is all to say that we're seeing lots more kids with diagnosed with ALD and are working on trying to sort through these MRIs. Fortunately, we have what we think is a great standard of care, in that we think it covers the bases in terms of keeping the kids safe and in a position where they're not going to be ineligible for bone marrow transplant, clinical trials, or safe and accessible therapies. That surveillance schedule, let me see where my mouse is here. Okay, there it is. Does come with some challenges, though. So I would say the MRIs are the most challenging part of that schedule for two reasons. One is they require, in the early ages, anesthesia. And two is they're really stressful for families because the stakes are high. You go into a study with your child always appearing well in this case, and you come out of this, and the stakes are, is everything okay for another 6 months, or are you going to need to be triaged for bone marrow transplant, which means reordering your life for the next potentially couple of years. It's a big stress. Franny Broussard gave a beautiful talk describing that process and the others that preceded it in great detail, as of others. But there's a lot of weight on these MRIs. So our goal is to try and make these MRIs more easily interpretable and make it easier. But to start with a little background here, we're starting in brains that are not fully myelinated. This is actually a neonatal MRI, but this is to show that the myelination in normal myelination begins kind of in the center of the brain, and it spreads outward over time at different ages. And this is visible on MRI to the radiologists and the neurologists, but even the radiologists, as you can see here, these bright areas here get darker over time on this one sequence we call T2, and on this other sequence we call T1, these areas where the myelin is, they're not filled in yet. You can see where the myelin is here, and it gradually spreads through the brain. So this is watching it in real life. Now, what is challenging for the radiologist and the neurologist is to timestamp this and say, okay, I have a brain here that is 18 months old. So what does normal myelination look like in that time frame? Because it is changing. This is just a qualitative map of myelination over time. So you've got this big period in early childhood, and then it stabilizes a little bit, and then you go to period in adolescence. But the point here is that myelination really is changing over time. And so these radiologists and neurologists are trying to, it's a bit of a moving target for interpreting the scans. And it is most challenging in those early years, those early couple of years. Fortunately, we have some prior knowledge that helps us know where to look for lesions. And so we can say with a reasonably high likelihood, in a young boy where the lesion is likely to appear. And it's very likely, not 100% certain, but very likely to appear in this region. This is what we call the splenium of the corpus callosum. And there are some lesions that can occur in other locations as well, particularly up in the front. But this is really what we're looking for, is early spots here. And I'll show some pictures of early lesions later. And what we're looking for is not just any abnormal signal, but it's a specific abnormal signal that means there is inflammation. And this is just a histologic slide showing, this is normal myelin, and then this is inflamed myelin and, inflamed blood vessels. This is what we're looking for. We're not looking for delayed myelination or just areas that are not yet myelinated. We're looking for something very specific. And on the MRIs, this is what it can look like here. This is what to us is a fairly obvious lesion, and I think to most radiologists, they would not miss this, something of this size. And the lesion, if left untreated with transplant, would progress in most cases to something like this. Now, the challenge for a radiologist who may have never seen someone with early stage ALD before, they may have seen advanced ALD, but this is a new era where they're seeing kids with normal brain MRIs and they're described as having ALD. So, well, where is the lesion in their mind in a sense? Or I'm looking for a lesion. So, okay, I have to look for something like this. So they get a scan like this, and they say, look at this, there's an abnormal area here, and I compare it to my map, and for someone of this age, it looks a little bit different. This image here is actually a normal 18-month-old brain. And so for a radiologist who's maybe saying lots of things, including brains and including, GI studies, this could really catch them off guard. And so this is, for families getting MRI scans done in most parts of the country, they may be working with radiologists who are not yet used to the landscape we now live in. And these kinds of findings, which are normal or maybe slightly age-adjusted, maybe it's a little delayed myelination, are being reported in some cases as lesions, and that's very disruptive and disconcerting for families and doctors both. So in addition to the lesion location, we also have age. Age is a really helpful predictor for us in terms of understanding, is a lesion likely now? And what we can say is that, there is a peak. And I'm going to go to the next, this is really where we're looking here. This is a more quantitative data set from Dr. Eric Malik. I've applied some numbers here that assume a certain total percentage, but this gives us a relative sense of proportion here. But really, lesions are not appearing. This is perhaps a slightly misleading view of this, but lesions are really not appearing before the age of 2. The way the data is spread out here makes it look a little bit different than that, but I want to sort of put this out there for families that lesions before the age of 2 are essentially unheard of. Even before the age of 3 are quite uncommon. But really in this, pardon me for trying to find the mouse here, there we go. We're looking with greatest interest in this particular age range between the ages of 3 and 10 in particular. Now, lesions can occur across the lifespan. I don't mean to, this is not me saying that these are the only ages we're looking at here, but we can use age to sort of gauge the likelihood of a lesion occurring. What we have to take into account is still, well, what is the age, what is the level of myelination we expect for someone of this age? And so this is still part of what we have to take into account. There's another thing we have to take into account, and that we're going to find things when you do a lot of tests on a lot of people. You will always find things that you weren't looking for. If you do a blood test for your, sodium level, some days or some moments it might be a little bit high or a little bit low in some cases, and it may not be relevant to what you need to decide that day. in medicine we call these incidental findings. So things that we find that we're really not looking for. And the American College of Radiology has their own definition for this because it's very common on imaging scans, because you may be looking for one thing, but you're capturing a picture of a whole bunch of things. And so that picture can come with unexpected findings. And I'll show you how common that is, but there is a prior literature showing that this is very common. So this is a study from many years ago, I think 20 years ago, showing the relative frequency of incidental findings in the general population. And I think where's the top line here, I think it was something like 20 to 30% have had incidental findings. Similarly with kids, there was similar findings. 1 in 5 kids had incidental findings on their brain MRIs. This is not ALD, this is just generally. And so for families getting these brain MRIs, your neurologist and radiologist are going to be looking for something that they're most focused on, but there might also be other things in those MRI reports. And some families have found this. I now have really taken great attention in trying to help families prepare for these kinds of things. But I have to say, initially, I was not always counseling on incidental findings, but when I started getting MRIs on kids either, it wasn't something that I registered as important as I realize it is now. Okay, so here's what we did in our center. So we said, okay, let's look at our population alone and just see what we're finding for incidental findings. And this is a picture of Jay Logana, the clinical research coordinator of my lab, who some of you have met. He helped to gather the data for this study, as did our nurse practitioner, Nicole Corwin. And so this is an IRB-approved study. We used basically a de-identified database in our health record system to look through all of the children, all the MRIs of children with a diagnosis of ALD, and we set criteria that we would include both intramural, meaning done at our hospital, as well as extramural, meaning done at other hospitals, reports. And we looked only at the reports. We didn't review the images ourselves. We just looked at the formal reports, both in the kind of reported findings and in there's kind of a detailed section that describes all the findings that doesn't always get put in the kind of the concluding features. We looked at both portions. And then we basically gathered all the findings, and I was the one who went through and tried to categorize them into different groups. So here was our demographic. We had 53 boys. In all of the boys, I should explain too, these were all boys whose initial brain MRI was normal. And then we followed subsequent brain MRIs. So in other words, in the spirit of newborn screening, where we're starting with a normal brain MRI, what do we see? So our median age was about 7. And about roughly half had VUSs. This is pretty similar to the newborn screening experience now. And we had a reasonable representative breakdown of race and ethnicity. This is just an overview of MRIs by age. In total, we had, sorry, I don't state our total number of MRI parts. I think it was stated on the bottom here. I think it was around 350 or so MRIs that we reviewed. So a lot of MRIs that were done over this time frame. This is from 53 kids. So here were the findings. So only about 1 in 4, and I say normal across all time, I should rephrase that to say no incidental findings ever reported across all studies is what I mean. All the MRIs most of the MRIs were effectively normal in the ways that matter. I'll elaborate on later, but meaning no incidental findings at any point. So only 1 in 4 really had no incidental findings reported. Here were the findings that were reported. We had a pretty large number with these non-specific punctate T2 signals, particularly in the frontal lobe, and they look kind of like this. So this slide here is maybe a bit more pronounced than we're typically seeing in our ALD kids, but this is what they look like. And those in general child neurology practice know these are really quite common. we see them most commonly perhaps in patients with reported migraines. So we get MRI scan to make sure there's nothing bad there causing the migraines, and we see these little spots. These are quite common. They don't have typically pathological meaning in general, and they do not, I want to reemphasize, they do not have any pathological meaning in ALD, either that we know of or that was implicated in this study. So I want to reassure people who see these findings in their reports, both in our series and in other series, these seem to be benign and non-specific, meaning they might be there, but it doesn't have any implications for things you need to worry about or things you need to do differently. And there were, I would say this was a little bit surprising to me. I'd seen this enough times before, it was just more prominent than I was expecting, in that there were signals here suggesting that there were some maybe shifts in the timing of myelination for ALD boys, not necessarily absence of myelination, just it seemed to maybe be happening a bit later than was the age-adjusted norm. And so this is part of the challenge for general radiologists reading these scans, is they see things that they're comparing it to their 2-year-old MRI myelination model, and they say, oh, this looks different, something must be wrong. This is part of the challenge. Other features here were prominent perivascular spaces. I don't have a picture of this, but this is also something we commonly see. This is benign, does not have any meaning here as far as we know. We do see this commonly in the general population and in all diseases. This one was actually the one that really got me interested in looking at our series. These were these non-enhancing, the term here is I'm borrowing from my radiology colleagues, curvilinear T2 signals. So the curvilinear means, it's following the pattern here. It runs around the curve of the, following along this curve up here. So these initially, when we first saw these, I was not sure how to interpret them. These were present on the very first scans we were getting on many of our kids, and they happened to be in the location where we were really looking for lesions. So they certainly caught our attention. Key feature here, these were in the areas we're looking, but they were non-enhancing, and they were typically present on the very first scan. They also, we had the virtue of finding out over time, they didn't change at all over time. They were generally persistent throughout the time period of scanning. They also had swelling, so those were helpful features. However, if you contrast this with an early pathological lesion here, again, you can't quite see it honestly, but this spot right here is an early ALD lesion that we scanned. This was done at an outside site, so I hope we would have caught it at our center, but this was a scan that, looking back on all the MRIs, it was visible in retrospect. And this was something that would look very similar to some of the findings we were looking for here. So this, though, over the time course of the surveillance for this child, did progress very obviously. Now, normally at our center, when we see a lesion like this is the kind of lesion we follow up sooner, get a repeat scan in 3 months perhaps to see if it's progressed. In this case, this was done at an outside center. I think they didn't see that early tiny lesion, which is very subtle, but it did progress a little bit further, and so that at that point the child was sent to bone marrow transplant. But you can see that, I think, for the clinicians in the room, and maybe even for the layperson, you can see these the subtle similarities between these scans. And then there were 2 boys who had this non-enhancing T2 diffusion-weighted signal in the central tegmental tract. I know that's a lot of technical language, but it was a finding that caught our attention because it can be observed in other neurometabolic disorders. It's often a non-specific finding, and it is a finding I've seen. These, I don't follow adults anymore, but I have seen it in AMN men in the past. This area of the brainstem can be affected. And these were boys, I think, both with variants of uncertain significance, incidentally, where we found these lesions on the very first scan, and they did not progressed thereafter. In fact, they became less apparent over time. So again, this is just a summary again. There were other features here that were reported, and we found one gray matter of heterotopia, a Rathke's cleft cyst, a lying tonsil, some asymmetry of the carotids. These are things that we do not think were related to ALD. And I'll also say, to reassure people, at least in this very small data set, none of these findings here that were, that other than the actual ALD lesion, predicted an ALD lesion. So as far as we can tell from our data right now, just because you're seeing, some report in your MRI that there's some alteration of myelination, that does not necessarily have any adverse prognostic feature that we can see in our data set to this point. So a little bit of reassurance for families on that point. So some limitations. This is just a text-based review. I did have access to most of the images, so I could look back and I could see what the radiologist was talking about. Some were done outside. I did not always have access to them. There were essentially 3 radiologists doing most of these reads, and we don't have a full follow-up on all these kids. But here are my conclusions. And these are good take-home messages for families and clinicians alike. Incidental findings are very common. So most patients will have, if you read all the text, at least in our center, the majority of kids will have some incidental finding reported, or what I would consider an incidental finding. Some of these findings go away with age. The myelination patterns sometimes improve with age, some of the other features improve with age. Others remain stable over time, which is also instructive. They don't change at all. And that includes those curvilinear features in the splenium. The cerebral ALD lesions were distinguishable from benign lesions by their location. Certainly the enhancement, no other lesions enhanced. We didn't see any other enhancing features, and interval growth. So those 3 things were clearly distinguishing them. I should also say there's often a bit of swelling around the lesions that can be distinct. The T2 signals in the splenium and the genu were the most difficult to triage initially as a clinician. Now I'm actually more used to seeing them, so I've come to expect some of them, and they're easier for us to distinguish. But the abnormal signals in the tegmental tract, we'll keep an eye on that. But again, no, we don't have any sign that these are pathologically significant at this point in the boys, and again, no incidental findings were predicted. So that's the end of my data set here, my slides. So I can take some questions, but open it up.
I just had a quick question about if there's any information in terms of speed of progression on lesions. So with newborn screening, you're going to find these kids really early and be in a really good position to intervene. And there's been some suggestion that perhaps puberty might have a mitigating factor. For boys that are identified, cerebral disease on diagnosis, you don't know how long it's been there, you don't know when it started, how fast it might be moving. Is there any evidence to suggest that earlier within that danger zone that it's diagnosed cerebral, that it's going to move faster than, say, as it gets closer to puberty?
So in this study, we were really focused on incidental findings, and so that kind of data we weren't analyzing or looking at. But based on Eric Malik's prior studies, the age does seem to be a factor in how fast things are moving, and I would say my impression is exactly as you stated it, that early life things seem to move faster, and then as the boys get older, the lesions seem to progress more slowly. But I think your expert is in the room right over there. Yeah, Eric, any comments on that? Yeah. Okay. He'll cover it tomorrow. Other questions?
This really has nothing to do with ALD, but I was just curious, does anyone know why myelination, that terminal myelination, that's popping up might be different like what would cause myelinating at different ages?
Well, it might be relevant to ALD in that there might be alterations in the myelination stages, like it might happen a little more slowly, which is ALD for reasons we don't fully understand yet. And I know that others have commented that in some adults they say, oh, the myelin here doesn't look quite normal. I think Ollie has said this many times. But for some people, there might be differences in motivation. I have to say it's not something that I think anyone has looked at quantitatively yet, though. Others have been doing neuroradiology studies in adult men might have a more detailed take on that. Why would it be different in general? So there are lots of things that can affect myelination. There's a very, very large suite of genes and developmental sort of timings that influence myelination, and those are manifested in all kinds of different ways in leukodystrophies in general. I would say we've often thought that ALD is spared from a lot of that, and it's certainly spared from the most severe forms, the most obvious forms, in terms of not having any real obvious problems in myelination. The stuff we're reporting here, I would say, is pretty subtle. If anything, it's maybe a delay in myelination for some of the kids. There were perhaps a couple kids where the pattern of delayed myelination seemed to persist for quite a while. Why would it be the case? We don't know yet, but perhaps some alteration in just fatty acid metabolism at the peroxisomal level is coming into play. I probably wouldn't expand too much further than that on it speculatively. Suffice to say, it is something we'll look at in the future with more dedicated myelination studies, probably in natural history studies, to see if there are differences between ALD boys and some boys without ALD. Was there one more question?
Hi, I'm Valerie and I'm in newborn screening, and newborn screening praised a lot for preventing families from going on diagnostic odysseys because we catch them early and they know the information early. And based on what you were sharing today, it sounds like we might be creating diagnostic odysseys for families. So my question is, how often are these incidental findings followed up on or lead to action for families?
That's a great question that we didn't look at most, but I can answer it anecdotally. You know what, I should add that to our analysis. As far as I'm aware, only one incidental finding in our cohort led to another study, and I don't even, now that I think about it, I don't think it was included in this. It was a fibroglossal duct cyst, and it led to an evaluation by our ENT colleagues just to see whether surgery was necessary. To reassure you, the screeners a little bit, actually it's not leading to any more further diagnostic stuff, it just leads to mostly conversations. Most of these findings, we see them, the clinicians, certainly that are familiar with ALD, know how to put them in context and say, okay, this is not the clarity for the workup. It could be the case that other centers, they might do additional tests if they were less familiar with ALD, but most of these are quite common just in general. Part of what we're doing here is just to try and quantify them so that clinicians and radiologists would have, the intent is to publish this as something of a guide for clinicians and radiologists and families too, so they can sort of help put these findings in context. Because if you're a family getting this information, even though the doctor says everything is fine, you might still worry that they haven't given you any more details than just that basic reassurance. This is helpful to the doctors and families both, I think, in helping them put those things in context. Yeah, I should also add that Eric Malik has sent me more data that we haven't yet incorporated in this, and we're interested in getting similar data from other sites. Eric's data look pretty similar to the data we had here. I think the findings were roughly on par with this, so, but more patients. All right, well, thanks very much. Any other questions here? I think we're at lunch here, so I think we'll